Good evening, everybody. It is pleasure to be with all our audience tonight for this presentation in the annual conference of Ain Shams University Hospital Hemodialysis. And I thank all the Congress Committee as well as AMGEN Pharmaceutical Company for inviting me to present this talk about the use of erythropoiesis stimulating agents in pre-dialysis chronic kidney disease patients. As all of us know, anemia is a frequent complication of chronic kidney disease. It occurring in over 90% of patients undergoing renal replacement therapy. The predominant and the most consistent cause is the failure of adequate production of endogenous erythropoietin by the kidneys. We know that erythropoietin is mainly produced from the peritubular interstitial fibroblast cells in the kidney, and to less extent it is also secreted by the liver. It is very important to stimulate the maturation of red blood cells in the bone marrow, and all the patients with CKD, from whatever the etiology, with continuing progression of their renal disease, as well as the development of renal fibrosis, loss of these very fruitful cells occurs with less production of erythropoietin, and hence the development of anemia. Of course, this is not the only cause, but as it is written here in the slide, is the predominant and the most consistent cause. There are many other causes, for example, iron deficiency, absolute or relative, increased red blood cell destruction, uremic toxin suppression of the bone marrow, etc., etc. But again, it is most importantly caused by erythropoietin deficiency. The development of anemia in patients with CKD, as we see in this slide, starts usually with stage 3. Okay, so stage 3 is usually called the stage of complications. Okay, as we see here, the anemia as defined by hemoglobin is less than 12 gram. It started to show up here in stage 3, but it becomes markedly increased in prevalence among patients with stage 4. And as we just read in the previous slide, it is present in about more than 90% in the patient who reach stage 5 or are under regular hemodialysis therapy. This is together with a lot of complications resulting from declining function of the kidney, like easy fatigability, hypocalcemia, hypoalbuminemia, hyperphosphatemia, etc. Also, the prevalence of anemia in patients who are non-dialysis dependent CKD patients in this study, as we see here with stage 3, it was prevalent in about 17.4%. It rose to about 50% in patients with stage 4 and stage 5, not dialysis required. Again, the prevalence of this anemia becomes more and more prevalent as we reach end stage renal disease and starting renal replacement therapy. Again, with rising of the serum creatinine, as we see, the column of prevalence of anemia is also increasing. Is also increasing as we see here according to the level of hemoglobin. When the hemoglobin is less than 10 gram, for example, in this orange area, in the patient with the serum creatinine more than 4, 62% of the patient will have anemia. What is the diagnosis of renal anemia, or at which level of hemoglobin we start to think that there is anemia and start the workup and the management of this condition? This is according to recent 2015 Japanese Society of Nephrology guidelines. They put this definition, which is not different from the well-known other guidelines. The definition of anemia, lower hemoglobin than this target according to the age category and according to whether male and female, as we see in this slide. Anemia in patient with CKD is typically normocytic, normochromic, and hypoproliferative. That is associated with reduced erythropoietic activity, which is consistent with insufficient erythropoietin stimulation. This is fundamental to the diagnosis of anemia that is related to the renal disease, because as all of us know, when we are confronted with a patient with CKD and anemia, it is usually related to his chronic kidney disease. But of course, we have to consider other causes that may be present. One of the reasons that make us go directly to diagnose it is renal anemia is its a characteristic type. It's a normocytic, normochromic, as well as it is hypoproliferative, as indicated by low reticulocytic count. What is the pathogenesis of anemia in patients with renal disease? As we said, the main factor is reduced EPO production from this failing kidney. Also, reduce the renal clearance of hepcidin. Hepcidin is a substance or a protein produced by the liver. It works to prevent the absorption of iron from the intestine. Iron is very important in the structure of hemoglobin. This hepcidin is much increased in patients with renal failure due to reduced renal clearance. And in the past few years, it take much interest and many studies are working on this hepcidin. Also, the presence of many uremic toxins in the uremic milieu of patients with CKD will result in suppression of the bone marrow, resulting in development of anemia. Also, the blood loss from shortened red blood cell survival that may be related also to uremic toxins will result in iron deficiency. That may be helped also by decreasing appetite, by the presence of excess hepcidin, preventing the absorption of iron. Of course, one of the reasons of increased hepcidin is the presence of inflammation in the uremic milieu. Again, patient with CKD that will result in anemia. There are many inflammatory cytokines are present in the patient with chronic kidney disease. These inflammatory cytokines will result in EPO resistance initially, as well as functional iron deficiency that will result in reduced red blood cell production and anemia. With more advanced chronic kidney disease, EPO will decrease and resulting in absolute decrease in the level of erythropoietin in the blood, again resulting in reducing red blood cell production, development of anemia. On the other way around, there is hemodilution. Hemodilution is caused by RAS activation in any patient with CKD, and angiotensin II will result in production of aldosterone, will result in increased reabsorption of sodium and retention of water. Also, the declining of the GFR will result in hypervolemia. This hypervolemia will result in a dilutional anemia. These are the two main operating factors in the development of anemia. What is the impact of anemia in the patient with chronic kidney disease? As we see from this slide, anemia will result in increased risk of coronary heart disease in patients with CKD, with more increase of anemia, as we see here with serum creatinine more than 1.5 in men or 1.2 in women. The prevalence of coronary artery disease is much increased in these patients. Also, anemia is considered as a risk multiplier of mortality in CKD patients. That is, if we look to the mortality in patients with CKD, if they have anemia alone, the mortality is this figure. If we add to the anemia, diabetes, and the chronic kidney disease, the risk will be much multiplied. If we add it to the anemia, congestive heart failure, together with diabetes magnified, If we add all these four, the risk is much, much magnified. So anemia actually is a risk multiplier for this patient. The consequences of the uremic state will result in volume overload, RAS activation, inflammation, hyperbara, hypertension, that is pressure overload, diabetes, atherosclerotic cardiovascular disease. All this will result in two problems in the heart, coronary artery disease as well as LVH. Again, the presence of anemia will result in high cardiac output, sympathetic nervous system activation, tissue hypoxia, plus deprivation that will result in oxidative stress, and this also will result in both coronary artery disease and left ventricular hypertrophy. Both of them will result in ischemic heart disease and congestive heart failure. And this is a serious link between anemia, chronic kidney disease, and the development of heart problem, whether heart failure or ischemic renal disease. It is called sometimes the cardiorenal anemia syndrome. Also, if we look to the pathogenesis of patients who have symptomatic heart failure from whatever the type, reduced or preserved left ventricular ejection fraction, there are many contributing factors for its development in patients with chronic kidney disease, among which the presence of anemia, one of the factors that will help the development and the progression of this condition. The development of chronic kidney disease and development of congestive heart failure will result again in cardiorenal syndrome and more progression of renal disease. Recently, they are speaking about the cytokines, and in the presence of inflammation in patients with chronic kidney disease, the production of cytokines, for example, interleukin-6, in itself, it is produced from the inflammation that is present in chronic kidney disease, and in itself will go to the bone marrow, resulting in APO resistance, and interleukin-6 that is produced from the inflammatory state in patients with chronic kidney disease will also directly damage the kidney, resulting in more renal fibrosis, more reduced production of APO, more reduction in erythropoiesis, and more anemia. And by this way, chronic kidney disease will result in more anemia, and the condition will continue in this way. Anemia adverse consequences are many. For example, lower quality of life, fatigue, depression, LVH, left ventricular systolic dysfunction, etc., as well as faster decline in kidney function. The symptoms of patients with anemia or impact of anemia in chronic kidney disease may be all these manifestations that will make the life of patient with chronic kidney disease going bad and bad. The patient feels that he is very tired, lack of energy, weakness, chest pain, shortness of breath, bruised skin, difficulty remembering things, etc., feeling distressed and feeling burdensome. All these are consequences of anemia in this patient. So what is the potential benefits of correction of anemia in this patient? It will result on the reverse of all the previous. It will result in better quality of life, exercise capacity, decreasing cardiac output from the high output to the normal, reducing angina symptoms in the patient, reducing left ventricular hypertrophy, etc. Actually, it is the reverse of the previous, and this will ultimately be translated in less need for hospitalization with its cost and less need for more transfusion. Again, decreasing risk of mortality, it is stated that for every 1 gram hemoglobin that is increased, the risk of mortality will be decreased by 5%. For every gram of hemoglobin that is increased by correction of anemia, there will be reduced the risk of hospitalization by 4%. Reduce the risk of infection, improve the quality of life, and regression of left ventricular hypertrophy. Now, in the last part of my talk, how we treat the anemia of patient pre-dialysis CKD patient, as stated by Professor Francesco Locatelli from Italy. We have to take a pinch of ESA as well as a pinch of iron and mix them with wisdom. That is the iron Today, we are speaking about the ESAs. The erythropoiesis stimulating agent has potential benefits, and like any drug, it has also potential risks. The potential benefit, it will reduce the need for blood transfusion, and it will improve the quality of life. Again, it will result in some risks that if we handle this with wisdom, this will not happen. The development of cardiovascular events, stroke, vascular thrombosis, as well as the development of hypertension. The role of erythropoietin and the iron in the development and the maturation of red blood cells is very clear in this patient, in this picture. Erythropoietin works in the early forms of red blood cells, and the iron works on the late forms, and the ultimate mature red blood cell is a consequence between the iron as well as erythropoietin together. What is the wisdom for the use of ESA, as said by Professor Francesco Locatelli? We have these three types of ESAs: epoetin alpha as example of the first generation, darbepoetin alpha, which is the example of the second, and methoxy polyethylene glycol epoetin beta, that is example of a third generation. Of course, if the half-life of the drug is increased, it will be more convenient, it will be more easy for the patient to take, for example, an injection every 2 weeks instead of receiving the 2 or 3 injections per week, etc. So one of the wisdom is to use this medication, the erythropoietic stimulating agent, by subcutaneous administration rather than by the intravenous route, and to choose one of the longer acting medication like darbepoetin alpha, for example, that will cover half-life by subcutaneous administration about 50 hours. That is translated into, we may use it, for example, every 1 week, every 2 weeks, and sometimes up to every 1 month. Again, this is a suggested starting doses for the different type of ESAs. If we are speaking about non-dialysis dependent CKD and we are using darbepoetin alpha, this is the usual starting dose, 0.45 microgram per kilogram, and this is to be given every 2 or 4 weeks. This is very important as compared to the short acting, in which the drug is given once, twice, or sometimes thrice weekly. Again, darbepoetin alpha in many studies proved to be the only medication among the ESAs that can be given in different schedule in order to help individualize every patient's circumstances, his needs. It can be given once weekly, can be given every 2 weeks, can be given every 1 month. But it is important to know if we are going to give this medication over a long time, I mean over 3 weeks, over 1 month, it should be given by subcutaneous only, not by intravenous way. Okay, again, several studies proved that compared to the short-acting ESAs, darbepoetin alpha resulted in overall 30% decreased dose or dose saving by the end of the studies in many patients, as we see here. This is published in NDT. Okay, 30% reduction in the dose is not only translated into money, but also one of the troubles that is attributed to the use of high dose ESAs is related to the high dose of the ESAs that will result in normalization of hemoglobin. So by reducing 30% of the usual dose of short-acting ESA by the use of darbepoetin alpha, we are reducing the cost and we are reducing the side effect if it is related to the use of high dose of ESA. Another aspect is the hemoglobin variability. In recent years, observational studies have shown that higher hemoglobin variability, that is even with reaching the target hemoglobin, but over time, hemoglobin is going up and down from the target. This is called hemoglobin variability. If this variability is high, this is associated with adverse outcome both in non-dialysis dependent as well as in end-stage renal disease. And this is a relatively recent study it stated that pre-end stage renal disease hemoglobin variability predicts post-end stage renal disease mortality in patient transitioning to dialysis. It is interesting enough that the mortality of this patient was mainly due to infection, not due to cardiovascular disease. Darbepoetin alpha may help in reducing this variability in hemoglobin, and as we see in this maintain study that used darbepoetin alpha in dialysis patient experiencing a severe drop in their hemoglobin, that with the use of darbepoetin for this subset of patient, the drop of hemoglobin was generally compensated without leading to overcorrection. These the guidelines from the KIDUKI, the American, as well as the GDIGO, the international, about the non-dialysis dependent patient for their hemoglobin. For the KIDUKI, it stated that the target to be 11 to 12 gram, but in the KIDIGO, they stated that don't try to make hemoglobin much more than 10 gram, and at the same time start to give erythropoietic stimulating agent if the hemoglobin is less than 10. If the hemoglobin reaches more than 11.5, we have to reduce the dose of ESAs in order not to shoot, because of the fact all of know higher hemoglobin level didn't improve the outcome. On the contrary, it resulted in bad outcome in patients who received the ESAs in order to normalize hemoglobin. And to summarize this story of target hemoglobin, if we look to this 10 to 11, as we go on this way, we have clear benefit with no evidence of risk. But if we're going on the other way around with higher hemoglobin, the risk of complication, including cardiovascular complication, is more than the benefit. So if we control the scale, the use of high dose of ESAs and reaching complete anemia correction, the risk will outweigh the benefit, as we'll see here, and this will be translated into overall cardiovascular and all-cause mortality. But if we make partial correction of anemia, and this partial correction according to just the stated guidelines, the benefits will outweigh the risks in terms of better tissue oxygenation and fewer need for transfusions. In fact, in order to conclude my talk, the wisdom in the use of erythropoietic stimulating agent, and this is my last slide, is the use of darbepoetin alpha will result in more convenient use of erythropoietic stimulating agent. We are using a drug every 2 weeks, every 3 weeks, every 1 month. We are using less dose, saving 30% of the dose, as well as it will result in less hemoglobin variability, improving the outcome of the patient with anemia and the chronic kidney disease. I hope that we get some information about the wisdom of use of ESAs among patients with non-dialysis dependent CKD. I was very happy in order to be with you, and thank you very much.